Hi, my name is Catherine Arcura, and this is my nutrition support case. My patient was admitted to the BICU at UMC with a 55% TBSA partial full thickness burn. Past medical history was unknown due to patient being intubated and sedated. A burn is damaged skin that causes affected skin cells to die. My patient is classified as both deep partial and full thickness. Deep partial is destruction of most of the dermal layer, whereas full thickness is complete destruction. Both of these type of burns can result in reduced to no pain due to nerve endings being destroyed. A quick MNT for a burn patient per Aspen guidelines is to ensure to initiate nutrition within 4 to 6 hours of the injury. Caloric needs can be determined by indirect calorimetry, such as metabolic cart, Ireton-Jones. Protein can be determined by 1.5 to 2 grams per kilogram per day, 24-hour UUN, or 25% of total caloric needs. And also ensuring to provide vitamin A, C, and zinc for optimal growth. Day 1, the initial assessment, patient was intubated and sedated. We were consulted to manage EN. The patient is a 22-year-old male. He's 6'3", weighs about 82.7 kilograms, is 90% of his ideal body weight, and his BMI is 22.2, which is considered. The current nutrition that's being provided on his initial assessment was Pivot 1.5, which was infusing at trophic rate of 20 mils per hour via NG2 per MD orders, and to keep these feeds at trophic rate for the next 24 hours. Pivot 1.5 is an elemental immune system support formula. This formula was chosen because it's enriched with arginine, glutamine, omega-3, and it's high in antioxidants. It's also appropriate for wound healing and patients who need high calorie and protein needs, such as my patient. The calories were determined by Ireton-Jones since metabolic cart hasn't been completed yet. Protein was determined by 25% of caloric needs, and fluid was 1 mil per kcal, and that's demonstrated as is shown in the chart. I highlighted the caloric and protein needs because I feel like per Aspen guidelines and just in general, there should be a range on the caloric needs, but since I was following my preceptor's rules, this is what we went with. With the trophic and flowing, we're only meeting about 22% of caloric and protein needs and only 11% of fluid needs, and we're at 48% DIR. So our PES is going to be inadequate or less than optimal integral nutrition related to current EN order versus estimated needs, as evidenced by a patient meeting less than 25% of estimated needs. Our recommendation or intervention is to keep the pivot at the trophic rates for the next 24 hours per MD and advance EN to the rate of 95 mils per hour for 24 hours to provide the optimal amount of nutrition. But we'll set the goal rate to 100 mils per hour for 24 hours to meet 10% overestimation of needs. This policy is determined through UMC. It's their ICU EN policy to always give 10% overestimation since patients in the trauma unit are constantly in and out for the OR and they're missing nutrition. So providing that extra 10% will make up for lost nutrition. You also want to provide additional 255 mils every 4 hours to meet. Here's a little hospital course catch-up timeline. After the initial day, the EN did reach RD goal. Day 8, there were some residuals, so prescribed prokinetics and the residuals were resolved. Patient was also experiencing diarrhea, which was prescribed Banatrol for 3 times a day. On day 10, patient was extubated. SLP saw patient, but SLP documented that he was not safe to transfer to a PO diet, so he's kept as MPO with other means of nutrition. Day 11, a DOPHOP tube was inserted and patient was tolerating ENs a lot more. Day 15, the liquid bowel movements have subsided and Banatrol was discontinued. On day 23, a reassessment was done. He was tolerating his continuous feeds. Pivot was at the goal from the previous metabolic cart with no signs and symptoms of intolerance. Fluid flushes were 250 every 4 hours per MD. There was no GI symptoms and regular bowel movements. Assessment needs were reassessed due to a new metabolic cart, and they are as presented in the graph. With the EN that was provided within the past couple of days before this reassessment, needs were meeting about 136% of caloric and protein and 112% of fluid and 312% of DRI. Since these were way over the estimation, our PES is going to be excessive intake and oral nutrition related to current EN order as evidenced by 2 feed, meaning over 110% of estimated needs. So our intervention is going to be recommending decrease in EN rate to better match recent metabolic cart to Pivot 1.5 at a goal rate of 105 mils per hour for 24 hours to meet the 10% over. On day 32, it was a reassessment and a consult. SLP saw the patient documented that demonstrated functional swallow with modified PO diet. So SLP cleared the patient for a high protein, high calorie, mechanically altered honey thick diet. Needs were reassessed due to a new metabolic cart, which is now presented in the chart. You can see the needs are not as high because the patient is doing well and is recovering better and doesn't need as many needs. Since from the previous EN order, now the EN is meeting 145% of estimated needs, which is way over. So our pediatric can be excessive intake and oral nutrition related to current EN order as evidenced by EN meeting 145% of estimated needs. Our intervention is going to be decreasing the EN rate to pivot 1.5, 75 mil per hour, but we want to do 80 mils per hour to meet that 10% overestimation. We're not going to decrease the EN rate until patient meets about 60% of estimated needs by mouth. And then we'll look into trophic or cyclic. That was the end of tracking my patient. Since I was an intern during tracking this patient, I finished my MNT 2 clinical rotations. Before my patient got discharged, from my knowledge, what was passed on, the patient completely transitioned from EN to a normal high protein, high calorie diet, just regular diet. Here are his weight trends. Since they did fluctuate a little bit, it could be the fluid, so we just use admit weight to keep it. And here are the labs that transitioned through his whole hospital course days. You can see most of the ones that were high are mainly due because of the stress in the incident that the patient was presented with at the hospital. And here are my references.